First of all, let me thank the Directorate of Public Health, the honorary guests. It's a great occasion to be here. Talking about history will add to your meals thing, but anyway, I'll try to keep it as short and sweet as possible. See, any health system or planning, all this goes by these factors. The health parameters, the society is our leader. Any prevalence, incidence, death rates, all these things, that only makes planners to move them, allot money or plan things. Various organizations get involved. Then the societal perception and expectation from a profession. And I talk in terms of nursing, what people think about nursing, what do they expect from nursing. Then comes the lifestyle of people. That matters to every profession because that contributes to the health of the individual. Then comes the policy makers. I think we spoke about the need for data. And the policymakers need a lot of data by which they make decisions to curtail those problems and appoint and provide all the other infrastructural facilities. Then the technological advancement also contributes towards any health sector. Then changes in health sciences, advancements, dynamics in the population, changes in the age groups, more adolescents now, more old age people. All this need to be focused when we plan for health programs. Then the professional aspiration. Each profession has their own development. So that also contributes towards the Now, I have planned to present like this so that it will be point by point, what was and what is now. So this way we can navigate quickly, I think. Previously it was illness. Illness was considered as a punishment from God. Now germs and various other factors are causing the disease. There was an infection era. And after Joseph Lister, we have arrived at disinfection era and we have advanced. Health was only for the privileged people. Now health for all, after the declaration of the Alma Ata in 78. Increased death rates were there. Now in India, the increased life expectancy is on average is about 70.8 years. For men it is 69.2 and for women it is 72. There was no guarantee of survival if a child was born. So people were getting more children as possible. Now there is a guarantee, even if one child is born, it will be alive. So the IMR is a witness. It has come down to 25.49 in 21, according to the 21 report WHO. Now, health was considered as an expenditure. The previous one. Health was considered as an expenditure. Now health is considered as an investment. Previously only we were talking about the curative service. Now preventive services or in full-blown action. Poor health infrastructure was there. Now accessibility is very good. Now our population, for every 5,000 population, you have a sub-center and a PHC, and then you also have the community health center for every 30,000 population, and adequately staffed. Now health as a government responsibility. It was a government responsibility. Now public-private partnership is there from the 11th five-year plan. Preventing communicable disease was our focus, like TB and malaria. Now preventing non-communicable disease has taken the focus. And diseases of poverty was there. Now disease of affluence, that is the focus. Previously our health implementation was through the vertical programs. Every disease had its own vertical programs. Now it is a horizontal program, or it is merged with a regular health program. And we had unipurpose worker for every disease. Now it is multi-purpose workers. Health was an isolated sector. Now it is considered as a multi-sectorial approach. Previously it was a purposive care only for a particular disease. Now it is a comprehensive care. Previously it was a long distance care. People had to travel a long distance to reach the health care. But now it is a teleconference care is possible. An increased MMR of 4, IMR 79, now it has decreased to IMR to 13 and MMR 90 per 1 lakh. Now decreased literacy of the public. Now literacy of the public has increased. The female literacy is almost, literacy is around 95 to 97%. Client was a receiver then. Now client is a participant in the healthcare. Individual focus was on a sick person. Now family focus on every family member. And previously we were bothered about the curative care only. Now we are bothered about the rehabilitative and hospice care, up to hospice care. And previously you have to save for your expense or borrow money. Out-of-pocket expense was very heavy previously. Now health insurance have come into stay. And lack of specializations in professional things were there. Now many specializations have come up even in nursing, like geriatric care, occupational, school health, hospice, and every area now specialization has come. Previously people were adopting to local technology. Now high-tech care has come into nursing. General health was considered or focused. Now specialized health services are given. And we had traditional nursing education. If you know, hands-on training were given to nurses earlier, or even Martuvachi, like this, she was conducting the delivery. But now it has become an institutional, and it is a regularized council-monitored education, specialized nursing education, like travel nursing, disaster nursing, all that has come up. Nurse was considered as a subordinate. Now nurse is considered as a team member. Then family planning was target-oriented, and nurses were running after people with money in their hand to achieve the targets. But now it is not so. Family planning is done voluntarily by women. And there was no presence of advocacy earlier. Now the presence of advocacy and association is present. And there are a few drawbacks also. People were depending on natural food then. Now we have to tackle the problem of artificial and fried foods and all the fast foods. And previously work was considered as an exercise. Now exercise is considered as a work. This is a focus which we have to concentrate. Theory and practical for basic care. And maybe this point may be good for nurses. But misappropriate nursing process, people who misuse nursing process, which was advocated by the American Nurses Association for a proper thinking and approach of patient care that was done, and that is slightly misappropriated. Decreased focus on community nursing, and now there is an increased focus on Indian focus by even Indian Nursing Council and even I think Medical Council, where we are giving almost 3 months of internship and 6 months of community nursing posting in the syllabus itself. So there is an increased focus for community nursing. And then poor acceptance of a nurse in a society. Earlier it was so. Now better tolerance or acceptance and appreciation for them. And previously they were considered as a submissive role. Upacharika. That's the word they used. And now lack of role clarity also is little bit is there, but with a higher education. As they climb on the ladder, still they have the lack of role clarity in nursing, but they are still accepted by the society better. There were increased home deliveries, now increased institutional deliveries. That's the focus, almost 95.5% according to 21-22 report. And then previously there was poor antenatal care, now there is increased antenatal care where the role of nurses, domiciliary care almost has risen up to 77%. Now previously healthcare and all the facilities were centered around cities. Now equitable distribution, now healthcare is available at doorstep. And earlier, unaffordable to many, now the healthcare is affordable to many. And it was inaccessible, now equally distributed, now it is accessible to the people. Previously there was no data or wrong data. Now increased evidences and the data is available. And community health nursing or nursing was following the allopathic. Now entrance of Ayush has come into stay. Data by experience and now by research, nurses are increasing their data. And previously there was private care, now public-private participation. And there were unorganized service. Now organized service as military service, which commenced in 1664. Mission, through missions, healthcare started in 1907 and 1910. And then civilian facilities, hospitals came up from 1797. And training schools of midwives started in 1854 in India. Now previously it was hands-on training. Now it is a regulated training from Indian Nursing Council since 1947. And State Nursing Council from 1926. And Tamil Nadu Nurses Council is the first ever nursing council started in the entire country because it was looking after the Southeast Asian countries. So that is how it is 1926. Previously people were cared at home. Now the care is catered in school, in prison or occupation areas and palliative sites. And the care is record based. Now you use mobile based. Previously we were sitting and writing all the records. Now all your planning, reporting and monitoring is done in your mobile itself. Traditional health teaching was there. Now high-tech teaching and mobile apps are used for even health education. Human insufficiency was there. Now artificial intelligence have been incorporated into the care. Promotion by seniority, even in the work area, previously they were only by promotion. The promotion was done by seniority. Now qualification matters and people are appointed by only qualified people are appointed. Then previously there was less scrutiny and now increased accountability of every worker is there. And unisectoral approach of health, now multi-sectoral approach. We have even the school system and agriculture, engineering, everybody comes into play into health, and that's how it is. the change of history. Now, I would like to say a few words about the future of community nursing. This is a profile of a community nurses in future should be, and she should be community based, versatile, computer competent, resourceful expert, culturally competent, bilingual or multilingual person, should be able to critically think, outcome oriented, skill, skilled case manager, and communication expert, an autonomous and independent person, and she should be able to coordinate. So these are the basic qualities a nurse in future is expected to contribute to the healthcare system. One thing is clear about the future of community nursing. It needs to evolve and drive the provision of care from being community based or being community focused. And now this is a recent one you have serving the community. Makkalai Thedi Marthuvam. We are taking the medicine to the doorstep of people. Now this is a model for the future. I myself developed one where we see the community at the bottom, where people go in the ascending tile. When they get sick, they go for health examination, whether it is a sub-center or whatever the health infrastructure. Then they order and receive investigation, they make clinical judgment. Then if it's a high risk, they refer to a secondary level. Then from secondary level, if not well, they go to the hospital. What is required is in the right side, you get the community coordination department. Every hospital, if they have a community coordination department, it will be very good to get back to the community. I think this was wonderfully done during the time of COVID. During the time, they wonderfully, so any person coming from outside, they were able to track and follow up. So that's the kind of thing we need for every disease, so that people will be healthy. And they come to the local community again, and they can be placed in any of the infrastructure that is available. And this is another entrepreneurship model where a nurse also can, in a specified area, she can, with her knowledge, will be able to cater to the need of people. Now, so many non-communicable disease in play, a nurse herself can be able to assist the people in healthcare. Like a nurse specialist will be able to appoint some assistants with her. Either the people can call her or she can call on them and then provide community service, and for which she needs these kind of skills in her education. So with these few words, I would say that community nursing had come up a long way, in the sense, along with the other professions, whether it seems to be a medical knowledge or with the engineering knowledge or the soft skills, people have progressed to come closer to the community and in providing this service to people. So this is in short about the history of community nursing in India.
Thank you for the pulse of your wisdom, sir. The podium is open for any questions or doubts. Okay. We cordially welcome Tirumati Sumati, Joint Director, State Bureau of Health Intelligence, to honor the speaker with a memento.